re-entry circuits. And so the drill is the same. So if you're within the Hangout, you can talk and actually ask me questions and interrupt me whenever you think there's something that I'm not explaining properly. Or if you're watching from the broadcast, you can type in questions, and I'll be able to. You can type in the questions in the Q&A app, which is on the top screen of the broadcast video. If you go to the top screen, there's a button with 9 squares in it. You press on that, then press the Q&A app, and then you're able to ask any question you please. So without further ado, I'll go into re-entry circuits and what they really mean. Now, the re-entry circuit, so in the heart, normally, if you take a piece of heart muscle, the heart muscle, in essence, is a little bit like a neuron. You have an action potential that can go through the heart, through a cardiac myocyte, by propagation of action potentials of, that's a bad drawing, by means of action potential which looks a little bit like this. A little bit different to that of a neuron, but still an action potential nonetheless, and you can propagate it along the cardiac myocyte. Okay, so normally in the heart, what happens when the sinoatrial node fires, normally what happens is just some revision. A sinoatrial node fires, and then you'll have what we call waves of action potentials, basically propagating throughout the atria like this, and then converging in the AV node, going through the bundle of His, and then into Purkinje fibers and into your ventricles. Okay, so you can see that the general direction of the action potential is in one direction. Okay? So that's what normally happens. In people with what we call re-entry circuits, what can happen is a situation can develop in which, instead of this sort of thing happening, you can have an action potential propagating through heart muscle in a circle. For example, like this. Now, if this happens, if you have an action potential going around and around the heart in circles, then it's going to keep causing adjacent myocardial tissue to fire repeatedly, independent of the sinoatrial node. So the re-entry circuit causes a tachyarrhythmia. The first question we need to ask is, what is it that actually causes the re-entry circuit to form in the first place? Well, couple of criteria are needed for this to occur. 3 criteria. Firstly, you need an actual pathway. And what I mean by that is, for example, one example of a pathway is if you had some heart myocardial tissue here, okay, if this whole tissue was healthy and you had an action potential going into the myocardial tissue over here, it'll propagate in all directions in one direction, and there'll be no opportunity for a re-entry circuit to occur. To have a pathway in the first place, what needs to occur is you need a region of tissue that is not myocardium. That could be scar tissue, that could be fibrous tissue, that could be part of the AV node, etc. You need a piece of tissue that does not count as myocardium, because what's going to happen is when an action potential reaches this area, it's going to split into two different wavefronts, sorry. Okay. And that is the start of a potential re-entry circuit going in this direction. So that's what I mean by a pathway. Okay. One. The second thing is you need a degree of what we call unidirectional block. What unidirectional block is that the action potential does not propagate in one direction through some myocardium, but it goes to the other way. And so unidirectional block So what happens here is, for example, if we had some myocardium and an action potential was trying to be propagated here, it gets blocked over here. But if the action potential were to come from this way, it will go straight through. Okay. The reason why you need unidirectional block is because if we go with this example of this scar tissue, okay, your action potential normally, if there was no unidirectional block, will split into two like this, wind around the scar tissue, and go straight forward, and no re-entry circuit can be produced because there's no block. There's no block over here. However, what can happen is if you had this scar tissue and you have your splitting of your wave fronts, and your wavefront on one side goes all right, the other one gets blocked, okay? The other one gets blocked. Then, because there's no action potential going on here, this wavefront can actually circle around this myocardium. And therefore, it'll eventually hit this region over here. Now, the problem is this myocardium has been depolarized. Okay? It is in the middle of its plateau in the action potential. If this is the case, the wavefront can't penetrate through this action potential because, if you remember, during the middle of an action potential, that is the absolute refractory period of that myocardium. It can't propagate or transmit a second action potential whilst it's already in the middle of one. Okay. So that brings me to my third criterion, is that there needs to be the time taken to go around the circuit. So the time taken for the reentry for a wavefront to loop around the scar tissue or whatever tissue there is needs to be greater than the time taken for the blocked tissue to repolarize. So, for this to occur, okay, a few things can happen. You can make the pathway very big. So if you had a very, very big scar, for example, a very big scar, then the distance that the wavefront has to travel is quite high. So that means there may be enough time for the wavefront to go round and round and round and round and round the circuit. By that time, this blocked tissue has already repolarized. And when it's already repolarized, this wavefront can go straight through, because if this is repolarized, this action potential can go straight through. And when it goes straight through, by that time, this tissue is repolarized as well. And then it goes along again and again and again, and you get your macro reentry circuit, the anatomical reentry circuit. So, one interesting point is that certain drugs like lignocaine, which is sometimes used to treat ventricular fibrillation, lignocaine can precipitate a re-entry circuit because lignocaine is a sodium channel blocker. So if it is a sodium channel blocker, it slows down the propagation of the action potential. And the reason it does that is because if you think about the mechanism of propagation of an action potential, sodium ions flow into the cell, and that's responsible for that initial spike in your action potential. And these sodium ions will propagate along the cardiac myocyte until it reaches the next the next set of voltage-gated sodium channels. Now, lignocaine is blocking these sodium channels. That means less sodium is going into the cell. You have a lower sodium current entering the cell. And if you have less sodium entering the cell, that means the sodium will diffuse along the cell this way a lot more slowly. Therefore, the time taken between this action potential and the one in the next batch of sodium voltage-gated sodium channels will be much longer. In other words, the action potential will take a lot longer. So drugs like lignocaine, what they can do is that drugs like lignocaine can make this action potential very, very slow. This wavefront is traveling very, very slowly. Now, by that time, when it arrives at the region of unidirectional block over here, that tissue has long since repolarized. And this action potential, this wavefront, will circle around the myocardium like that, again and again and again. And that's what a reentry circuit is, and that's how you form a reentry circuit. Now, moving on. Let's talk about the revising. You need a pathway, a region of unidirectional block, and you need a pathway that is either big enough, distant enough or slow enough so that you have enough time for the reentry pathway to go around the circuit before the blocked tissue has repolarized. Sorry, after the blocked tissue has repolarized. So, what kind of tachyarrhythmias can reentry circuits cause? The classical one is AV nodal reentrant tachycardia. This is your classical SVT. AV nodal reentrant. Okay, so AV nodal reentrant tachycardia, also known as AVNRT. This is a very common form of supraventricular tachycardia. It is quite a benign form of tachycardia, tends to happen in young women, especially people who tend to drink coffee, people who tend to take central nervous system stimulants such as amphetamines, people who people who are anxious, people who have thyrotoxicosis, people with holiday heart syndrome can get AVNRT. Holiday heart syndrome is a set of tachyarrhythmias you can get after binging on alcohol. In fact, binging on alcohol is a cause of atrial fibrillation, but it is also a cause of AV nodal reentrant tachycardia. So, what is AV nodal reentrant tachycardia? Well, it turns out that some of us, if you actually go into the AV node, have this anatomic reentrant pathway that I was talking about. It actually has a region within the AV node, that causes the splitting of a waveform. So this is from the atria, and this is into the ventricles. So you may have heard of the fast and the slow pathway. I can't remember exact details of what repolarizes first, but the important thing is that this is a typical reentrant pathway. So in certain instances, for example, if you have an ectopic beat, an ectopic beat can cause a region of unidirectional block, because what happens is, let's say an ectopic beat arrives at the AV node. An ectopic beat arrives here at the AV node. Let's suppose that during this time, one of your pathways has repolarized, whereas the other one doesn't. In fact, of these two pathways, one of them tends to repolarize more quickly than the other pathway. So, you have a heartbeat from your atria and the impulse from your atria going through these two pathways and hitting your ventricles. This segment is depolarized. Then click, one pathway repolarizes, then click, the other pathway repolarizes. If in between that time an ectopic beat comes along, what can happen is, well, if one section has repolarized and the other section hasn't repolarized, then, for example, your action potential is going to go only in one direction. So you've blocked this pathway effectively. So when that happens, your action potential goes along like this, and down. Now, by the time it arrives here, this section has repolarized, because remember, let's forget the fast and slow. This one repolarizes first, this one repolarizes second. And this ectopic beat has come on in between these two times. So then it comes along like this, and by the time it arrives here, this section has repolarized, and so the action potential will be propagated along here. And then again and again, it circles about in a circus movement, causing a supraventricular tachycardia and AV-nRT. Now, how do you stop this? Well, this is a rather convenient tissue for this reentry circuit to occur, because this is the atrioventricular node. This is the atrioventricular node, which has impulses coming from your vagus nerve. Okay, there's impulses coming from your vagus nerve. Now, your vagus nerve your vagus nerve can actually block conduction, because if you have any reentry circuit, okay, if you want to stop the reentry circuit, all you need to do is block it somewhere. You can block it here, you can block it here, you can block it here, you can block it anywhere along this region. Okay. And to block it, all you need to do is prevent the propagation of the action potential. In other words, all you need to do is prevent, in this case, the influx of calcium ions. Because if you remember correctly, AV nodal tissue and sinoatrial nodal tissue, their sodium channels are permanently inactivated, because the resting membrane potential of your sinoatrial and atrioventricular nodal tissue is quite high. It is quite, it's not very negative, which means your sodium voltage-gated sodium channels, which are in your sinoatrial node and your AV node, these sodium channels are completely and persistently and permanently inactivated. So if you can use a calcium channel blocker to prevent the propagation of the action potential, that's also fine. Calcium channel blocker. Now we also know that this sinoatrial nodal tissue, the resting membrane potential is increased by beta-1 receptors, okay, by a variety of mechanisms. Okay, therefore, if you block the beta-1 receptor, you can actually prevent the action potential from occurring by hyperpolarizing the membrane. And so therefore, if you increase vagal stimulation, hyperpolarizing your AV node, if you use a calcium channel blocker or if you use a beta blocker, which are rather benign drugs, unless you've got heart failure, but anyway, that's absolutely fine. Another drug you can use is adenosine, and adenosine, for some reason, tends to block the AV node particularly well. I can't remember the exact mechanism. So, when you get this sort of arrhythmia, how can you use the vagus nerve to terminate the arrhythmia? Well, if a patient comes in, a young 30-year-old woman comes in to your emergency department and she's got, you check your ECG and she's got classic supraventricular tachycardia, classic AV-nRT, what I would do is ask her to put her thumb inside her mouth and blow hard on it for about 10 seconds. What I'm basically asking her to do is called a Valsalva maneuver. And what a Valsalva maneuver is basically when you're contracting your diaphragm, but you're not letting any air out. So what you're effectively doing is you're squeezing your thoracic cage, you're squeezing the thorax by pushing your diaphragm into the thorax. And when that happens, you close your great vessels. Okay? You close the superior vena cava and you close your inferior vena cava. When this happens, your cardiac output, your venous return will decrease. So you're now in the Valsalva maneuver, you're blowing hard against your thumb. So your venous return decreases a lot because you're squeezing your superior vena cava and inferior vena cava. Your venous return decreases, and therefore your cardiac output and subsequently your blood pressure will decrease. Okay? Your blood pressure will decrease. Then what happens is after 10 seconds, you ask the patient to let go, to stop blowing into a thumb. You subsequently quickly expand the thoracic cage. You expand the thoracic cage, and what eventually happens is, you suddenly increase the venous return into your right heart. When you suddenly increase the venous return into your heart, you will stretch the sarcomeres in your myocytes. You will increase the contractility of the heart and the preload of your heart. You increase your preload, and therefore your blood pressure will increase. And that's purely due to the increase in venous return. The sudden increase in blood pressure is detected by your baroreceptors, the receptors on your aortic arch and carotid sinus. When you have a sudden increase in blood pressure detected by the stretch receptors in your aortic arch and your carotid sinus, they basically modulate your baroreceptor reflex. Your baroreceptor reflex, what it will do is, it will cause a vagal stimulation of your sinoatrial node and your atrioventricular node in an attempt to slow down your heart rate. So when your vagus nerve is stimulated by your baroreceptor reflex, the AV node will be blocked. This re-entry circuit will terminate. So this is a quick, simple, and easy measure, non-medical, to treating patients who have AV and RT. And the reason is because the re-entry circuit passes through the AV node. So if you block any region within the AV node by using a vagal maneuver, you should be absolutely fine. Adenosine also, for some reason, has a property of blocking the AV node. Can't remember the exact mechanism. So, moving on. Let's talk about the other type of junctional tachycardia, so AV nodal tachycardia, called AV reentrant tachycardia. And this is also known as AVRT. Okay? Now, AVRT is basically an AV tachycardia, AV reentrant tachycardia, secondary to an aberrant accessory pathway from the atria to the ventricles, which is also known as both Parkinson-like syndrome. And effectively what happens is, if you were to have, I do apologize for my lack of artistry, but just bear with me. If this was the heart, these are your atria and these are your ventricles. So your ventricles over here, and I'm separating them with a septum. So these are your valves, etc., etc. So what happens is, I'll take out the valves. So I'm not doing a cross section of the heart. I'm actually looking at the whole heart over here. you have an aberrant pathway called the bundle of Kent. So the fact that we have a bundle of Kent fulfills our first criterion. You actually have a re-entry pathway, a potential re-entry pathway. Because this re-entry pathway, you could have an action potential going directly from your atria to your ventricles over here, moving up through your AV node, and then back into your bundle of Kent. So this is a potential. This is a potential pathway. So we've fulfilled our first criteria. The other two criteria, which are a region of unidirectional block, and an adequate amount of time for the wavefront to do a full loop of the re-entry circuit to allow time for repolarization, depends on the heart, but from time to time, those two criteria can be transiently fulfilled. So this potentiates, the Wolff-Parkinson-White syndrome potentiates from, at intervals, of AV reentrant tachycardia. Now, so therefore, remember my general principle. If you have any AV nodal, if you have any reentry circuit that's causing a tachycardia, all you need to do is block the pathway, block this reentry circuit anywhere within the reentry circuit, and you'll terminate that pathway. Because the pathway is going circle, 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 circle like this, and then you block it suddenly over here, the action potential stops. The action potential doesn't work anymore over here, and that breaks the entire circuit. That re-entry circuit is stopped. Okay, so the really convenient thing is that this tissue is AV nodal tissue. That region is the AV node. Okay, this region is the AV node. Now that is quite useful and very convenient for us because we know exactly how to block the AV node. You can use vagal maneuvers, so such as the Valsalva maneuver. You can use adenosine. And if you remember, the contraindication for adenosine is what? What is the contraindication for adenosine? Asthma. You do not give adenosine to any patients who have asthma because adenosine can cause bronchospasm. So it would be a very bad idea to give adenosine to patients with asthma. And as I discussed before, you can use rate-limiting calcium channel blockers, or you can use beta blockers. All of these drugs work on the AV node particularly well. So therefore, the treatment for AV-NRT and the treatment for AV-RT are practically the same. Now I'm going to give you one more tachyarrhythmia a reentry circuit can cause, which you would not imagine would be caused by a reentry circuit. The one that I'm talking about is called atrial flutter. Now, atrial flutter, the really interesting thing about atrial flutter is that everyone who has atrial flutter, almost everyone who has atrial flutter, has the exact same reentry circuit, and it goes within it's within the atrium. And from memory, it's around the tricuspid valve. So if you were to draw the heart again, right? The tricuspid valve is here. The reentry circuit goes effectively around your tricuspid valve, not directly around. There's a more elaborate pathway, but the interesting thing is the frequency of spins is 300 per second. 300 per second. Therefore, 1 spin, 1 impulse. 2 spins, 2 impulses. 3 spins, 3 impulses. 300 spins per second, 300 revolutions around the circuit means 300 impulses into your ventricles. Now, obviously, your AV node is rather good at filtering out. Your AV node is relatively good at filtering out ridiculously fast inputs from the atria. And the reason is because your AV node conducts action potentials pretty slowly. So that means by the time your second AV node, or by the time your second impulse from your atria arrives at the AV node, it may still be depolarized because it's taking quite a long time it may still be depolarized. So, which means we know the number of revolutions per second of this particular circuit, which means that your ventricular rate is usually exactly 150, almost always exactly 150, because your AV node usually does what we call a 2-to-1 block. It blocks every second impulse, which means that if you see any patient with a supraventricular junctional tachycardia with a heart rate of exactly 150, you're thinking atrial flutter. You have to think atrial flutter. After all, atrial flutter is a specific type of atrial tachycardia. After all, it's a tachycardia that originates right within your atrium, and it's caused by a specific reentry circuit in your atria. So if you see a heart rate of about 150, even a heart rate of 75, which can occur in a 4-to-1 block, you can suspect atrial flutter. Classically, you'll get what we call a sawtooth pattern. So classically, you get a sawtooth pattern, etc. But the sawtooth pattern doesn't always occur, which is why any patient with a supraventricular tachycardia with a heart rate of exactly 150 suspect atrial flutter. In fact, you could view the sawtooth pattern particularly well if you had a patient coming in with a supraventricular tachycardia, and then you suspect, okay, this could be AV-nRT, and then you give them adenosine. Adenosine will block your AV node. But that's going to be practically useless for atrial flutter because the reentry circuit is here and your AV node is over here. So all you're doing is blocking the AV node, so you're blocking the impulses into your ventricles. So if you give the patient adenosine, that ECG will become just the sawtooth, because the sawtooth is caused by your atria, the propagation of the action potential around the atria. That'll last for a few seconds, and then you'll just go back to typical atrial flutter because adenosine has a half-life of only a few seconds. So yeah, that's atrial flutter. Okay, so yeah, so basically that's the basis behind the reentry circuit. Now, does anyone have any questions at this point in time? Type them out. So I noticed that there's a couple of viewers who are viewing into the broadcast. So on the top of the screen, you'll see you see a button with about 9 squares. Click on that. Click on the Q&A button and type in any questions. Type in whatever questions you have, and I'll be able to see them. No questions? Okay, so yeah, that's all I wanted to talk about today. So I hope you enjoyed I hope you enjoyed this particular shoot, and I hope that you got a lot out of it. And I will hopefully see you next week for the next webinar. Okay, thank you very much.